Darolutamide in combination with ADT in patient with mHSPC Phase III ARANOTE trial. So, several Phase 3 trials have demonstrated improved OS and delayed progression to mCRPC when ADT is combined with an ARPI. The ARASENS and PEACE-1 trial we have that demonstrate survival benefit with a triple combination of darolutamide or abiraterone respectively along with ADT and docetaxel. However, these doublet and triplet regime underutilized and many patients with mHSPC continue to receive treatment with ADT alone because of concern about drug accessibility, tolerability, safety, drug-drug interaction and healthcare provider education. Thus, an unmet need remains the treatment that delay progression to mCRPC with recognized tolerability. So this ARANOTE trial, this is Phase 3 double-blind study that investigates the clinical benefit and tolerability of darolutamide plus ADT for patients with mHSPC. So they included PS01 patient randomized in 2:1 darolutamide 600 mg BD along with ADT versus ADT. So primary endpoint was radiological progression-free survival and secondary endpoint was OS time to initiation of subsequent anti-neoplastic therapy, time to mCRPC, time to PSA progression, and rate of undetectable PSA, and time to pain progression. So, ARANOTE had broad eligibility criteria to ensure the study population is representative of current real-world patient with mHSPC. Inclusion criteria was patient should receive ADT within 12-week performance status 0, 1 or 2, adequate bone marrow, liver, renal function, and they included both de novo as well as recurrent disease. They excluded the regional disease, baseline superscan patient who received ADT more than 12 weeks or either patient have received a second generation ARI, radiation or chemotherapy before randomization. So this is the baseline characteristic of ARANOTE trial. So these approximately 70% patients have de novo disease and 70% have high volume disease. As we can say, they included high volume patient was around 70% and low volume disease was around 30% in both of the arms. Among them, around 11 to 12% patients have visceral mets. So this is the result of primary endpoint. So darolutamide plus ADT significantly reduced the risk of radiological progression or death by 46%. So here we can see at 24 months in placebo arm there was 52.1% and in the darolutamide 70.3% are radiological progression free. So these benefit darolutamide show a consistent benefit across all the group, as we can say in all subgroup classification in disease volume. Low volume disease patient have more benefit than high disease. So darolutamide show a benefit across all secondary endpoint. So all OS, time to mCRPC, time to PSA progression, time to initiation of subsequent systemic therapy and time to pain progression. So in all kind of secondary subgroup have benefit. So even although OS is mature at 2 years, but darolutamide plus ADT reduce the risk of death by 19%. So this is the graph showing darolutamide delay time to CRPC and time to pain progression, which are both key patient level endpoint. So in time to progress to castration resistant prostate cancer in placebo arm, it's median around 13.8 months. In darolutamide arm, it's not reached. And same for the time to pain progression for placebo arm, it's 29.9 months versus in darolutamide, it's not reached. So a greater proportion of patients in the placebo arm versus Nubeqa plus ADT receive subsequent systemic life prolonging therapy, which is docetaxel. So in placebo arm, around 30% patients have received docetaxel, which is the line which is known for improve the OS. A similar rate of treatment emergent adverse event across treatment arm, lower rate of discontinuation due to A in darolutamide arm. So leading to permanent discontinuation was 6.1% in darolutamide and 9% for placebo. So these are the old trial of darolutamide, which show that there are good tolerability for the darolutamide, allow patient to stay on treatment discontinuation rate. So in ARAMIS trial, which was for the non-metastatic CA prostate, we can see that there are similar side effect for ARANOTE trial, which we are discussing, and ARASENS trial, which was a triplet therapy for high volume disease. So darolutamide's proven tolerability is supported by low discontinuation due to adverse event in the real world setting. This is the graph which is showing all ARI, darolutamide, apalutamide, enzalutamide in concern of drug-to-drug interaction, because many of these patients are elderly patients, and many of these patients undergoing a different kind of medication for like cardiovascular disease, hypertension, dyslipidemia, diabetes mellitus, depression. So we can say that darolutamide is safe in all subgroup of the patient. So out of all patients included in this trial, 70% of patients had Gleason score more than 8, 71% had de novo disease, 71% had high volume disease, and 20% patient had visceral mets. These patients met the criteria for trial testing triplet therapy, but some were randomized assigned to receive ADT alone as the control treatment in the ARANOTE trial. The author attempt to justify this choice of control arm by arguing that treatment intensification is underutilized, and 30% of patients in the real world with metastatic HSPC receive ADT alone. So to conclude, darolutamide plus ADT in mHSPC, so it significantly reduced the risk of radiological progression or death by 40% compared to the ADT alone, and associated with 19% reduction in the risk of death, although OS was immature. And the treatment adverse event were low and similar to the placebo graph. Discontinuation due to the adverse event, a measure of tolerability, was lower in patients receiving darolutamide versus placebo. Thank you.